greetings, everyone. Welcome to the 199th session of the online Optom Learning Series, OOLS. And for today's session, we have with us Dr. Glenda Aleman-Moheeputh. Dr. Glenda has received a Bachelor of Science degree in Vision Science and also a Doctor of Optometry. She has been working at various positions in terms of primary eye care optometrist. And recently, she has ventured out a lot into myopia management. She's the founder and CEO of iSmart Vision Care, which is located in Miami, Florida. And her practice primarily specializes in providing multiple solutions for myopia management. She believes that we are somebody as primary eye care optometrists who need to fight and have a mission in terms of fighting against myopia. With that in mind, she has been educating, lecturing across the globe on how to go about myopia management, not only to optometrists, but also she's keen to educate patients as well. OK Love is something what she's very much involved into, and it provides and offers consulting designed to educate fellow optometrists on various methods of implementing myopia control practices. With all that experience, Dr. Glenda is going to take us through what are the myopia control strategies and what are the pros and cons of the treatment as well. So welcome, ma'am, onto our platform. Thank you so much, for taking out a Sunday morning time for us. And let me just, leave the screen time to you.
Good morning, everyone. And thank you so much, faculty, for having me here. It is my pleasure to share my knowledge with everyone and hope that by the end of the lecture, you can take something with you and start implementing it. And if you are already practicing myopia management, I hope that you can take something valuable to add to your practice and elevate what you're already doing. So without further ado, let's get started. Myopia management is such an extensive topic that we can talk all day and every day about it. So today we're going to focus on going through each treatment option and the pros and cons of each one. These are our learning objectives. So we're going to go through each treatment and understand the benefits of each one, which one is more suitable for each type of patient depending on their own specific needs. And we'll also talk about the importance of consistency and compliance. And we will learn about some clinical cases that I have to share with you. So this is the million-dollar question, what is myopia? And all of you know that already, so I'm not going to bore you with definitions. But the bottom line is that myopia affects the quality of life of our patients. And, to me, that is the reason why I focus so much on doing myopia management, because when I have a little child sitting in my chair asking me, doctor, are my eyes getting worse? Am I going to go blind? That to me just stirs my heart. And it gives me a reason for doing this every day. This is the International Myopia Institute definition. And I think this is very important that we all adopt this because it's giving us a uniform global definition. And now all clinicians around the globe, we have some guidance, we have some standards that we can follow so that we can manage patients across the globe, having some standards and uniform definitions. So a refractive error in which the rays of light entering the eye parallel to the optic axis are brought into focus in front of the retina when ocular accommodation is relaxed. So I just wanted to share this one definition with you because I think this is the one definition that now has been adopted globally. And it's important that we all are in the same page. Now, stages of myopia. I know we have a lot of clinicians, a lot of students, so you are familiar with this. And we know that pre-myopia, it's anywhere where we have a 6 to 7-year-old child with a refractive error that is less than plus 75, up to a minus 50. Once they become minus 50, according to the International Myopia Institute, that constitute the diagnosis of myopia. Myopia is anywhere from -50 to -3, and we all are very familiar with high myopia. Now, I want us to focus today on pre-myopia because pre-myopia to me, it's power. Recently, I was in New York City doing a lecture, and I asked the audience to think of one word that meant myopia to them. And I want to invite you all to do the same thing. Think of one word that summarizes myopia for you. For me, my word for myopia is power, and I'm not talking about the refractive power. So I'm going to share with you why, in my case, myopia is power. And if you can share on the chat your one word, it would be very interesting to see the responses that come through. To me, pre-myopia, it's power because it's giving us the power to delay onset of myopia. And we know that delaying the onset of myopia for 1 year can have a cumulative absolute result in power reduction, depending on the child, anywhere from a quarter diopter to 1 diopter. And I like to focus on that because if we can prevent or delay the onset of myopia by 1 to 2 years, we can all have a part on this, whether you are practicing myopia management in an expert level capacity or you're just beginning to get into myopia management. I think it makes it a lot easier for us to intervene, and without having so many resources available. We in America are very fortunate that we have so many tools in our toolbox to help our patients. But lecturing around the globe, I realized that that is a privilege that not every clinician has. I have clinicians from Nigeria calling me and giving me cases that are very sad, and unfortunately, they have very limited resources. So I think that if we put our attention in pre-myopia and really focus on educating, raising the awareness, and having early intervention, it doesn't matter where you are in the world. Now you have the tools where you can all have a positive effect on the myopia epidemic. Now, we all know that once the child has 6 diopters of myopia or more, that increases the risk of pathology. And my apologies, I realized I mislabeled my slide. But the third bullet point is supposed to be high myopia, which is any refractive error of -6 or greater. And continuing with my conversation on why it's so important to delay myopia and to manage it when it's very, very low or even very mild, because each diopter matters. So this is, again, by a great work by Mark Bullmore and Noel Brennan. And we know that each diopter that we can delay or slow down the progression of myopia has a significant impact on the patient's life, because 1 diopter of increase in myopia is associated with 67% increase in the prevalence of myopia maculopathy, which is the leading cause of blindness worldwide. And this is just an illustration because a picture says 1,000 words. So I know for me it's early. So if you're in America, it's early Sunday morning. So you can just look at these pictures and understand what we are trying to prevent. So in order to manage myopia, it's important that we understand how to monitor myopia. So monitoring myopia, and I am privileged enough to have biometers in my clinic. So I do monitor myopia progression by measuring axial length, and hopefully one day that will be the gold standard. But I do realize that in some countries, it is a great financial burden to have a biometer. Resources are very limited. So we have to use the tools that we have at our disposal to help our patients. So in countries where, if it is difficult for you personally to have a biometer in your clinic, we can monitor myopia progression. We can assess the risk factors, first determining progression. So it's very important that if we do not have a biometer in our offices to measure axial length, that we are taking a very good history about the refractive error of the patients. So asking the patients to bring all the old glasses that they have, asking them to bring their previous prescriptions, getting prior history, it's really important so we can determine how much this patient has been progressing in 1 year. Because if we know that one child is progressing a quarter diopter, they have a lower risk of progression compared to a child who progressed one whole diopter in 1 year. And I am seeing in my offices patients who are progressing 3 diopters in 1 year. So having that information is critical to determine the risk factor for that patient to develop high myopia. Once you have the refractive error, you also need to assess, let's say you have a patient who is 6 years old and they have a plus 50 dioptric power, you can assess the risk factors because now we need to determine, are the parents myopic? What are the conditions of this child? There are kids here, for example, that live in apartment buildings where it's really difficult for them to go outside and spend time outdoors. So it's important that we assess the risk factors. And last but not least, definitely one of the most critical, it is axial length. So if we have the capacity, we are able to own a biometer, then definitely this is the best tool that we have right now to monitor myopia progression and assess the risk factor of any particular child to develop high myopia. These are the genetic factors. So we know that a child with one myopic parent is going to be 1.5 times more likely to develop high myopia. And when the child has 2 myopic parents, that is going to double and triple the risk of that child becoming myopic. We also now know that the strongest risk factor for developing high myopia in a child is the age of onset, which is why my focus is on pre-myopia and low myopia, because this is where we as clinicians, regardless of the demographics and where we are in the world, this is where we can have the biggest impact, and we can do it with resources that we already have available to us. So age of onset, when we have a child who is 6 to 7 years old and they have already any refractive error that is minus, that child has a high risk of developing high myopia by the time that they are 18 years old. Ethnicity plays a role, definitely. So we know that African Americans in a recent study had the least amount of progression in over a 3-year period compared to Asians, Hispanics, and Caucasians. And we also know that they stabilize the youngest, although I have to be honest with you, this is not what I am seeing in my office. But again, these are results from a study. And we know that Caucasians, even though they don't progress the most, but they do take the longest time to stabilize. So Asians, we know this is well known that they have the absolute highest myopia at the age of this stabilization. Now, a relative risk, we all talk about this all the time, and let's not forget to share with parents how important it is that they monitor screen time, and we want to minimize the screen time and expand or increase outdoor activity. However, it is important to know that as of right now, this is a relative risk factor because we just don't have the evidence supporting that it's an absolute risk factor for developing myopia, but we do know that has a negative impact. So we do need to limit screen time to no more than a total cumulative of 2 hours a day for kids. Now, I wanted to share the care for myopia. This is work by Brennan. And I really like this. If you guys have a chance to look for his paper, I recommend it. And the care, it stands for, the C in care stands for cumulative, because as we know, when we start treatment, if you are measuring axial length in the beginning of the treatment, you're going to see a decline. There's usually a tiny reduction actually in the axial length. But a few months after that, after 6 months, after a year, we noticed that the effect of the treatment is going to slow down. So this is why we need to look at the cumulative effect of the treatment rather than just looking at what is the axial length the one day. So we're not looking at one snapshot. We got to look at the continuity and the cumulative effectiveness of the treatment over time. Absolute. So we have to be careful to differentiate between patients of different backgrounds because, as we just mentioned before, the ethnicity, the risk factors is going to have a different effect on the patient's myopia. So we need to be looking at, when we look at progression or we're monitoring myopia progression, we need to look at the absolute value, taking into consideration the ethnicity and other risk factors of that patient. And reduction and elongation is, of course, the R and the E. So cumulative absolute reduction and axial elongation. So looking at the effect of the treatment over the course of the years for that patient. So we can't talk about myopia management without talking about how important it is to measure axial length. And we know how important it is because regardless of the treatment modality, whether you're doing ortho-K, soft disposable lenses, soft multifocal lenses, or dual focal lenses, or spectacles, the way that we're going to monitor this is by, they all aim to slow down the elongation of the eyeball. So all treatments are aiming to reduce the elongation of the eyeball or the rate of what is changing. So it makes total sense to monitor the axial elongation. So benefits of measuring axial length is we know that refractive error is not as reliable. If we are going to use refractive error in our clinics, then we need to make sure that we are doing it under cycloplegic conditions so that we can have a more reliable result. We also know that axial length is a lot more accurate when we compare it to change in refractive error. So axial length is repeatable, reliable, and more accurate when we compare it to refractive error. There's so much variability when we're trying to get a subjective refraction. So this is really important, and really this slide here, having this information changed the way that I treat my patients and I design my therapies for them, because having the information, knowing what the normal axial length is based on the age of the child really gives me a sense of what is the risks of this particular patient. So this is important to understand. So we know what is normal. So when you have a child coming in and if you have a biometer, then you can compare where that child is and where compared to an hemetropic child. So at age 6, a child should be around 22.36 millimeters. At age 9, they should be about 23.10. And we know that after 15 years old, the axial elongation is going to slow down, at least in theory, because again, I am seeing kids that are 16, 17, 18, and they are continuing to progress. So this is the typical change in axial length. So we know the baseline, we know where a child should be depending on their age group, but we also need to understand that axial length is also related to physiological growth. So not all the elongation that we are seeing in a child is attributed to myopia progression. If we have a 6-year-old child, they have many years still to grow. And so that child, their axial length is going to change at a higher rate than a child who is older. So between 4 to 8 years old, a child is going to have a axial length change or growth, which is attributed to their somatic or physiological growth of about 0.30 millimeters. So if you're having a child come in and that's the change that they have, you actually should not be too concerned about myopia progression. If you have a child who is 8 to 12, you see that it drops significantly. So a child who is 8 to 10 years old, their normal change in axial length for a year is 0.2 millimeters. And as they get older, that change in axial length over time is going to be less. So basically, to summarize this slide, younger kids have a higher rate of change, and we need to keep this in mind when we're looking at axial length change over a year, so that we are accounting for the physiological or somatic axial elongation, that it is not attributed to myopia progression. Now we have the growth charts that gives us some normative data where we can have evidence-based information that is going to help us do a better job at managing our patients, especially when you have affluent, you're in affluent areas with patients who are highly educated. They are coming in and they have already read this information. They have all the basics of what myopia is and what the treatments are. At least this is what I have experienced in my office. So having this information is critical for some clinics. When I started, we didn't have this information available, and we all been doing it without it. But this is giving us an additional tool now that can help us better educate parents and really, as clinicians, provide us with a tool where we can now assess more accurately, more objectively, the risk of a child becoming highly myopic over time. So let's talk about the treatment options. Luckily, nowadays we have many options. And again, because depending on the area where you are, you may or may not have access to all treatment modalities. It's important that we understand all the tools that we have so that we can utilize whatever is our disposal. Obviously I'm in US, so I have made this lecture for a US audience, and these are the 3 treatment modalities that are currently available in the US, but we also have other options overseas, which are your conventional multifocal soft lenses, and we can use progressive or bifocal glasses. We know that their effectiveness is not as good as ortho-K, atropine, or dual focal lenses. But when we have nothing else available, even if we can have an effect of slowing progression by 29%, it's something rather than nothing. Well, we should not be prescribing any longer our single vision glasses. So ortho-K, for me, I like ortho-K for kids who are very active, kids who are in any type of sports, but especially kids who do water sports. So children who are in swimming teams, water polo, sports, football, soccer, baseball, any sports, you name it, and they are a great candidate for ortho-K. So given that they have the right corneal thickness, they have the right parameters, their prescription fits into ortho-K. If they are active and the family can also pay for the treatment, this is usually one of my top choices to start the patients on. Low-dose atropine, it's another great treatment available. To me, atropine, I use it for my younger patients, and it's also a gateway to get patients started in myopia management. I love low-dose atropine because when I present it, I always present either a contact lens solution and atropine. I always present atropine because when the parents are not ready to go full into something complex like ortho-K, starting with an eye drop that they put at nighttime, it's an easy transition, an easy way for them to help their kids. And last but not least, dual focal daily disposable contact lenses. We know we have 2 that are used worldwide for myopia management. They are all great, and we know that they are very effective. All treatment modalities are effective when used correctly and properly. So it's really important that we emphasize compliance with these treatments. And this is a huge one because this is a myopia intervention that really costs nothing. It doesn't cost anything to us or the parents. Again, this is what, when we have those pre-myopic kids, we need to be emphasizing that they need to spend more time outdoors. We know that kids who spend 2 hours outdoors had less progression, and we know that time spent outdoors needs to be prescribed to every child who is pre-myopic to try to delay the onset of myopia. We don't really know if once myopia is set in, if time outdoors helps, but I think every clinician is still actively prescribes and recommends spending time outdoors, but we do know that it has a significant impact on children who are pre-myopic. So we now have also all kinds of spectacles for myopia management that are coming in. They are all have shown very good effectiveness on the studies that have been done. So I'm really excited for that. Unfortunately, in America, I do not have access to those lenses yet, but we're very excited because we know that it's going to be coming soon. We also have here, we have a company by Luma who's working on a new low-dose atropine that is going to be single dose, stable at room temperature in individual vials. So very exciting news on treatments for myopia management. Lots of new lenses, orthopedic designs coming in. We had recently with Johnson & Johnson coming out with their myopia control lens has really put a lot of awareness out there. They're doing great things with their marketing. So anytime we have big players in the industry, like CooperVision or Johnson & Johnson, I think that's always positive because they have all the resources to do a lot of the marketing and get the word out there. We know that one of the biggest challenges that parents are not educated about myopia. They don't understand myopia progression, and they really don't know that there are options for slowing down myopia. So I think this is a great time, and I am new to myopia management in the sense when I see my colleagues who have been doing it for 30, 40 years. But there's just in the last 10 years, there have been so many exciting developments. So let's talk about each treatment. So we'll talk a little bit about Ortho-K. We know that it's an RGP lens that uses reverse curve designs to reshape the cornea, and it corrects the vision for the patients, and it allows them to be free of correction. We know that according to the LAMP study, they slow progression by 59%. And we all know that it flattens the central cornea and it steepens the mid-periphery. And this allows for the treatment of myopia and for myopia management. Benefits of Ortho-K, I think the benefits are obvious. Biggest benefit, of course, is that patients are free of correction during the day. They love this, and I think that clinicians need to focus on that when we are presenting Ortho-K because this is what patients understand. So I share with my patients, this is why you want to do Ortho-K, but then I share with the parents, this is why I want to do Ortho-K on your child. But we need to, when we're presenting these treatment options to parents, we do need to appeal to their desires, and we need to really give them instant gratification. So even though we know that we're doing this for the long run, we're doing this for the benefit of slowing progression over time and for this child to have less risk of pathology later. This is something that is very hard to sell. It's very hard to make a child understand that we have to do this so that you don't have maculopathy 50 years from now. So having them see the immediate results. So I focus more on giving them the instant gratification. We start Ortho-K today, tomorrow your vision will be so much better. You won't need to wear glasses. Especially one big thing that gets kids more motivated about Ortho-K is when they have braces. I literally have patients said, I can't have braces and glasses at the same time. So if you see a child who has braces, kids are very sensitive, and even, they might not say anything, they do care about their appearance. And I've had multiple kids come to the office saying, I want ortho-K lenses because I don't want to wear glasses and braces. Definitely the biggest benefit for us is that we know that it's very effective at slowing down progression. But I think the biggest benefit to the parents is when they see their kids being so happy, because ortho-K really does improve their self-esteem. They do much better in school, and they do a lot better in the sports. I have seen this, and this is something I learned from my parents and patients. They told me, I would say, what do you like most about ortho-K? And they would say, oh my gosh, I'm so much better at soccer now that I don't have to wear glasses when I'm playing. Like anything, not everything is pink and rosy. So these are some disadvantages of ortho-K. And unfortunately is that there are limitations. And we do know that at least in the US, the FDA approval for ortho-K is up to -5 diopters of myopia. Doesn't mean that we cannot do ortho-K beyond that point, but beyond that point, the risk of an adverse effect is a little bit higher. So when we do correct higher degrees of myopia, which I do, we do have to be a lot more vigilant, and we have to be monitoring those patients in a more frequent basis. So one of the limitations for most clinicians is that if you are going to be using a pre-manufactured ortho-K lens that is commercially available, there is going to be a limit. Most companies, their ortho-K lenses have a limit up to -6 diopters of correction, and that is the spherical equivalent. And there is a limitation on how much astigmatism distance is correct, and it's 1.5 diopters of with the rule astigmatism and 0.75 diopters of against the rule astigmatism. Ortho-K, if you have been practicing for a while, then you didn't get this taught in school, or you did, but you have forgotten, it will require some special trainings. So at least here, when you want to do ortho-K, most doctors are going to go to Vision by Design. They're going to go to some bootcamp classes or attend a master class to learn ortho-K, because we want to feel confident. We want to feel like we know what we're doing when we treat our patients. So it does require specialized training. Every company that offers an ortho-K lens does require, at least in America, that you obtain a certification first. Certifications are not bad. They usually take anywhere from 30 minutes to an hour. However, when you have a busy practice, even taking out 30 minutes out of your day to sit there and just do a training, it's going to be a challenge. So another barrier to clinicians studying or getting going with ortho-K is that it does require, if you want to do ortho-K properly, you want to have a topographer. Now, in countries where we have very limited resources, I think it would benefit clinicians to maybe get together, and 2-3 clinicians can get together, buy one piece of equipment, and they can share. I discussed this with my friend from the College of Optometry in Nigeria, because they have very, very limited resources. So they're actually getting together, a group of optometrists, and they're going to pitch in and buy one equipment and have it in one office, and then have patients come there to do their topos. So I think that is a much better option than just not doing ortho-K without a topographer. But these are, I wouldn't say so much the disadvantages, but the challenges of starting with ortho-K. And one disadvantage or challenge, it is the comfort of the lens. So this is where we have to be very good clinicians and provide our patients with the proper solution, the proper instructions, so that we can make their journey with ortho-K easier and more pleasant. So this is a case of a 19-year-old. And because he is 19, we're going to look into a design that has a bigger treatment zone. This patient is a college student, and this was his prescription, -375. This is his topos on before treatment. And this is histography and 1-day follow-up. Obviously, this is a patient who is driving, so we want him to have minimal disruption from halos and glare. So we went with a treatment zone that was a little bit larger for him. He is doing great. He came for 1 night follow-up, and his vision was already 2025, in 2030. And in 1 week, the patient was 2020. So Ortho-K works every single time. One thing that you do want to keep in mind when you are starting with Ortho-K, definitely look at the case, make sure that the patient has an average for Ortho-K. Steeper corneas are going to do better with Ortho-K than flatter corneas. So if you have a cornea that is too flat, you really have to look at how many diopters you're trying to correct. And the other very important factor you want to look to increase effectiveness and the treatment, it's definitely the E-value. So this is E-value, the average is about 0.5. And if we have a higher E-value, you're going to have a better response with Ortho-K. If you have a very low E-value, this is the eccentricity, the rate at which the cornea flattens are going out to the periphery. The lowest E-value you have, then you're going to have a harder time with Ortho-K. So these are the things that you want to look at. You want to look at the prescription, the case, and the E-value before we decide if this is a patient that is really suitable for Ortho-K. Now we'll talk about atropine. So we are all very familiar, and this is probably one of the treatment modalities that is available. I know that some of the challenges in countries, in other countries, is that it cannot be prescribed by optometrists. So we need to partner up with our colleagues, ophthalmologists, so we can co-manage those patients and get the eye drops prescribed by them. We know that we don't really know exactly how it works, but we believe that the antimuscarinic receptors are the ones that are working on treating or slowing down the progression. And the youngest that I have treated in my office is 3 years old. I love atropine to get the patient started. Then we want to monitor. And usually I'm changing my patients into another modality within 2 to 3 years. Benefits of low-dose atropine is that it's very, there's no RX limitations, so we can literally prescribe it to any patient who is myopic. We do have different concentrations, so if we have a patient that has a lower risk, we can use a slightly lower concentration. I like to start with 0.03%. And if the patient, I don't see the desired effect, then I'm going to increase it to 0.05%. But there's no limits on the prescription. So this is one of the benefits that we can use it for patients that do not meet the qualifications for Ortho-K or even for soft disposable contacts. I also like the fact that I have the ability to play a little bit more with the price of the treatment. So when I have patients who really want to do myopia management for their kids, but maybe financially they can afford treatments like Ortho-K or soft lenses, atropine gives me the option to give them something until they can plan better and do one of the other modalities, which surprisingly is usually the case. They usually start with atropine and they see the effect of the treatment, and that gets them motivated to jump into something like Ortho-K or soft disposable multifocal lenses. It's easy to apply. So again, parents don't have such a hard time with Ortho-K. I love it, but let's just face it, it is challenging. The first week is going to be very challenging. So with low-dose atropine, again, easy to instill the drops in the patient's eyes and no really special equipment needed. Again, biometry would be ideal, but when we have little resources and we're just trying to help our patients, if we can put them on atropine and monitor their change in refractive error, that we can be proactive and we know that we're helping those children. And if we can send them maybe every 6 months to an ophthalmologist to get a biometry reading, that would be great. Now, the disadvantages of low-dose atropine is, to me, the biggest one is the compliance, because it's hard for patients to really see the effect of the treatment. They use the eye drops every night, but when they come to the office, when they wake up and they don't really see the difference. So I notice that patients are less compliant with atropine. And the side effects, so in places where you do have patients with light irises, it is a little bit more challenging because patients with light irises do have sensitivity to light, so they are more symptomatic to atropine. So for these patients, are usually going to recommend either a contact lens solution, or when we have the spectacles, that would be my other choice. Patients still need to wear glasses and contacts. When I prescribe low-dose atropine for a patient, I'm usually going to also prescribe a progressive with a wide corridor, a short corridor, and I'm going to have them measure in transitions as well, and then have them measure the set height at 3 millimeters higher than the pupil. So progressive glasses can get pretty costly too, so that is another of the disadvantages. So this is a case that we did with atropine. I chose atropine for this child because she was 9 years old and the age wasn't really an issue, but this particular child was not fan of contact lenses, and also the cylinder for her was challenging. She had 4.25 diopters of cylinder on her left eye. So in this case, I chose to treat her with atropine because that was the best choice. Obviously not a good candidate for soft dual focal lenses. Her axial length, as you can see here, is 24.19 and 24.21. And my apologies, because these are very, very small numbers here, but if you can see the axial length, it stayed very stable with treatment. So over the course of a year, there was just the expected change of 0.2. So we had a great effect. Atropine does increases astigmatism. So that is just something that you want to keep in mind. I have seen a slow creeping up of the astigmatism for patients who are in atropine. And last but not least, dual focal daily disposable contact lenses. So we know that these lenses, we have a couple of designs. One of them, there is an extended depth of focus, but they all work similarly by inducing the myopic defocus on the periphery. The parameters for these lenses, one of the companies has a wider range. They usually can go up to -8. And the biggest limitation with the dual focal lenses is really that they do not correct astigmatism. They only correct up to, or I would put patients that have maximum up to 1 diopter of astigmatism, because I don't want them walking around with blurred vision. Now, the benefits of the daily disposable lenses, they're super easy to fit. So you don't have to have a topographer. You don't need special equipment. They also have very low number of visits. So it's like whenever you fit a soft disposable lens, the same way you're going to do it. You're going to bring the patient in, have them back for 1 week follow-up. And then we're going to see them in 3 months and 6 months after that. So very easy to incorporate into any practice, whether you're super busy or you're just starting. There's no special training needed. You do need to get certified to fit these lenses. But overall, it's an easy transition, and it can also be combined with low-dose atropine. Measuring axial length, we know that is the best way to monitor the effectiveness of the treatment, but we already talked about that. Now, the disadvantages of the daily dual focal lenses is that we have limitations on the RX, as I already discussed. And here in America, it is very high cost to doctors. So they cost about $750 for one particular brand. So the cost for the patient is going to be higher year after year compared to Ortho-K. Patients still need to get glasses. So I think as far as cost goes, this is over time, maybe one of the more, higher cost options. This is a patient that this patient is high risk. You already see she's 10 years old and her axial length is already 26.10. However, this patient, because of time limits, parents could not bring her to too many ortho-K visits. So we opted to go with dual focal lenses, and we also went with atropine since she already has an eyeball that is longer than 26 millimeters. So this is a great example of when to implement dual therapy. So in this case, this patient, she's 10 years old. Her axial length is already at 26.1 on the right eye and 25 on the left. So to me, this is a high risk patient. So I went ahead and just started her immediately with dual therapy. So we did atropine and we also did dual focal daily disposable lenses. So I think the key takeaways from today is that myopia is not just a refractive error. There is no safe level of myopia. And if we can intervene when the patient has very, very low myopia, we can have a significant effect in this child's life. Monitoring axial length is essential for myopia management. So if available, this is a great tool that we need to be using in our offices. And finally, I think what I really wanted people to take away today is the importance of delaying the onset of myopia, because this doesn't matter if you're in Nigeria, if you are in Colombia, in Honduras, or in Vietnam, and you have very limited resources. We all can do something about delaying the onset of myopia. So we need to be advocating for eye exams early in the child's life so that we can be proactive and be prescribing outdoor activity for patients, monitoring their screen time before myopia onsets. So I want to end with giving you some tips for implementing myopia into your practices. So if you are not yet practicing myopia, these are a few points that you want to consider when thinking about opening your clinic. So first, you want to establish your treatment parameters. So understand, if you want to start doing ortho-K, you don't want to start with a -6. You want to start with a lower myop so that you can have a better chance of having success with your first treatments. Do your first few cases that are easy and then expand from there. So it's important that when you get started, you set your own limitations. You say, okay, you know what, I'm new to ortho-K, so I'm going to start doing anywhere from -1 to a -4. This is important. You're going to get tempted to do those higher cases, but I will tell you that for your own benefit, it's best for you to get familiarized, do a few easy cases before you start taking those more complex cases. Also decide the age of patients that you're comfortable with. You are all great clinicians. We all want to help our patients. That's what we come into the office for. But we also want to make sure that you are enjoying yourself while you do that. So having an age that you are comfortable with, it's really important. So if you are not comfortable seeing 2-year-olds or 3-year-olds, you need to tell your staff, okay, my youngest patient I'm going to see is 6 years old or 8 years old. So set that limit, the boundaries, so that your office can flow better and also you can enjoy what you're doing. And those patients who are younger than what the age that you're comfortable with, find a colleague who is comfortable seeing infants to, any other age. It is also important that before you open your clinic, before you start seeing patients for myopia management, that you have set at least your fee schedule. So when you are setting up your fee schedules, you can set up a global fee. This is great because this avoids you as the clinician having to choose a treatment just based on cost, but also avoids the parents just going with a treatment based on cost. So this allows for you, the clinician and the parent, to really choose the treatment that is best suited for the child based on their specific needs and their lifestyle. However, global fees are not always feasible. There is a lot of economic challenges everywhere. So we do need to be mindful that some parents may not be able to afford a global fee all at once. So we can also break it down into initial visit, then charge for follow-ups, and then charge for the treatment separately. You could also break down your global fee into monthly payments. Also, make sure if you are in America, we have several options that we can offer financing to patients. So there is Alphion credit, there is Care Credit, and so many payment options now where patient can purchase now and pay later. So those are all great options to get patients and parents to buy into these treatments for their kids. And finally, I want to leave you with this, because when we are going back to our clinics, ultimately, we all have a decision every day. And this is that in any moment of decision, the best thing that we can do is to do the right thing. The next best thing is doing the wrong thing. And the worst thing you can do is to do nothing. So thank you. And I think now we're going to have some questions.
Thank you, Dr. Glenda, for that wonderful messages, I think, and also the cases, really, really nicely seen cases, and with the follow-ups, and you had put all the eggshell lens and things like that. So thank you for taking us through the journey of what you do in your practice.
Thank you, it was a pleasure.
Yeah, just gonna straight away dive in directly. The first one was about the atropine. So was in your practice or your experience, is there any age limit for the atropine? When do you start? I know you said that your youngest was 3 years old, right. But would you have a different strategy which comes to different age groups in terms of the concentration and things like that? Any idea?
Yes, so there is no, to my knowledge, there is no really limit on atropine. We have been using atropine for myopia and for different reasons in optometry for hundreds of years. So there is no really age limit. However, I think the general consensus is that most of the studies that have been done with atropine have been with the youngest child has been 3. So we like to rely on studies. We like to practice evidence-based medicine. And we normally look at the studies kind of to have a guidance as to what we do and what we take. Now, when you look at a study, you have to take that information. And now you, as the clinician, you have to interpret it and use it to give the best treatments to your patients. So if I had a younger patient, if I had a 2-year-old patient who I know has a high risk, is already myopic, I would start them already on atropine. Fortunately, I haven't had that case yet. But if I had a child who was younger than 3, to me, there is no age limit to start myopia management. So now answering the second part of the question is, do I do it based the same concentration for different ages? So I think the question, to answer that, no, I don't use the same concentration, but to me, it's not about the age of the child. It's really about the risk of that child becoming highly myopic. So what you got to look at is, if I have a 3-year-old who is already a -3, that's a very high amount of myopia. So I'm going to start that child with the highest concentration on atropine. But if I have a 10-year-old that comes in and they are a -3, it's a very different scenario that we're looking at. And the risk of that 10-year-old to become high myopic is less compared to the one of the 2-year-old. So I might start the 10-year-old on a lower dosage. So when we are trying to decide the concentration of atropine, I think it's important to assess the risk factor of the child. So if you have a younger child with myopia, you're going to start with the highest concentration versus an older child who has low myopia.
Right. And how long, you can go ahead with atropine without any complications? So any thoughts over the complication part of it with atropine?
So, myopia management is a dynamic process. We should be really monitoring our patients and the effectiveness of the treatment. And when we notice that, I think the general consensus right now in the myopia management community is that after a few years, each treatment kind of has a plateau, and we are encouraging to change treatment modalities so that we can have a better myopia management or myopia control. So in my case, the longest that I've had any one particular patient in atropine is 3 years. Usually what happens is I start the patients on atropine, and in 6 months to a year, they usually are going to be starting ortho-K or contact lenses. When I do have patients that are just on atropine, so far the longest I've had any one particular patient is 3 years, and that patient is actually going to be going into ortho-K soon. There is no real limit that we know of, but I think the longest that we've seen a patient on atropine is 5 years. A lot of the studies have been done for 3 years. So I used to, when I started and I didn't know much, I used to say, oh, we can only do it for 3 years, but we know that that's not the case. Also very important to remember that we are taking a patient off of atropine, we need to taper them, that we cannot just stop atropine.
Yeah. Okay, I think the next question is probably some confusion, but I'm just putting it across. It says that myopic defocus contributes to the progression of myopia, or it helps to reduce axial length. So anything you would like to add on?
So myopic defocus, so there are two different theories, right? And it's the hyperopic defocus and the myopic defocus. So I encourage Mohammed to look into this. If you email me privately, I can send you a study to clarify this for you, because I don't want to confuse more people. So I'll send you, if he can reach out to me privately, I can
Sure.
send him some information to answer this question.
Awesome, great. And moving ahead, in terms of the dual focus lenses, does under or overcorrecting have any impact on myopia progression?
So with dual focal lenses, you want to address this fit just as you would any single vision patient. So you're going to fit the patient with the dual focal lenses, then you're going to bring them back to your exam room, you're going to assess VAs, and you're going to do an over refraction. So with this, we want the patient to have their full correction for myopia. So you are going to finalize the fit. So if the patient is a -4 and you put in a -350 set of lenses, and then you do an over refraction and the patient takes another quarter, you want to give them that quarter because you want them to have that clear vision, and the myopia correction is going to be done by the design of the lens. So you don't want to leave them overcorrected or undercorrected. You want to leave them on their balanced prescription.
So there is no scope of over or under correction, whether it be any myopia control strategies. We want them to correct fully.
We want to correct, right? Exactly, the most accurate correction for them. So we don't want the patients having any blur with these lenses. We want them to have their best correction, and the lens is already designed with, the design of the lens itself is what's going to do the myopia management.
Right. And somebody is asking if you have any experience in low light level red light therapy. So anything on that? And
so the studies, I did read one, and my apologies, I forgot to incorporate this into the lecture, but the studies look very promising. And what I like about this is that it's something that I can see in the future is going to be prescribed and is going to be done at home. So it's a short period is done for like 10 minutes at a time. So I think it's going to be a great resource and a great tool. It might make myopia management available, to remote places where they might not have access to atropine or to ortho-K lenses. So I think it's very promising. The studies so far have shown that it's an effective treatment. So that's something that I'm excited to learn more about. Unfortunately, we do not have it here in the US, so I have no experience with it personally. My knowledge is just from reading the studies about it.
Yeah, a couple of studies have come in and they are promising, but I think yet to be commercially available in many parts of the world, right? So, yeah, as you said, we are waiting. Anything comes in for myopia management, we want to look at evidence and see which one can help our patients well.
Absolutely.
Okay. Another one is more like a case and asking your opinion. If you have a high myopic -14 with a -5, 9-year-old child, how would you kind of go about treatment or helping this patient? What are your thoughts on this?
So, so this is a little bit controversial because, we have a lot of colleagues that will not do ortho-K beyond a -5 or a -6, because this is what the FDA approval is. So there is, I think most clinicians will not prescribe ortho-K for this patient. This patient is challenging. Of course, we would have to have like the Ks and the E values to really determine if there could be any partial reduction with ortho-K. And, definitely combine it with atropine. And you need a higher dose of atropine because just based on the refractive error and the age of the child, we know that this child is already at a high risk. Now, this is almost identical to a case that I had where I had a patient who was -1475 with -475 SIL. So very, very similar. I did ortho-K for that child, and I was actually able to get him down to seeing 20/30 uncorrected. So it can be done. Again, if you are going to do something like that, it would have to be a custom design ortho-K lens. And but if you want to be, more conservative, you can also do partial ortho-K correction and then have the patients wear glasses during the day. What we wouldn't want to do is, I never like doing ortho-K and then doing soft disposable lenses because I don't want the patients to be wearing contact lenses 24 hours a day. There are soft toric lenses, like we know that they're used off-label. So you have the Biofinity XR. That's a good option where we don't have access to other resources. So that would be a good choice. I would do a custom soft lens for these patients. And ultimately, if they just don't have access to contact lenses as an option, then we are left with progressive or bifocal glasses combined with atropine.
Right. Yeah. So I think some of these cases are more like you have to look at each case by case and off-label treatments, and you have to do all these permutation combination therapies.
Yeah, basically everything we do here would be off-label, except
everything off-label
is off-label, technically speaking, in the US because it's not FDA approved yet.
Right. Okay. All right. And I'll take one last question, ma'am, here. And I did listen, and you did talk about the company aspect and how are these big companies playing an important role. But would you like to highlight a little bit upon how they will be of use for clinicians, probably some early adopting clinicians who are starting myopia management? Would you have some guidance for them? Yeah.
Yes, definitely. So this is thank you to Christiana for bringing up the question, because I think this is a great resource that we take for granted. Sometimes maybe we just don't know that it is available, but and this is why it's so cool. And I'm so excited that these big companies have joined the fight on myopia because they have the resources. So I happen to be a speaker for Johnson & Johnson, and I'm also a consultant for Johnson & Johnson. So Johnson & Johnson has done an amazing job as putting together a package for providing assistance to clinicians. They have trainings available. I mean, their local sales rep will come to their offices and train the doctor, train their staff. But not just Johnson and Johnson. I know companies like Cooper Vision, Euclid. I mean, most companies that are providing ortho-K lenses would be more than happy, and they have training available, whether it's in person or they offer free webinars all the time. So it's reach out to, first of all, you have to sort out, there's several companies that are doing ortho-K lenses. So once you've figured out which company is the best match for you, reach out to them and ask what resources they have, because pretty much every company that I know they have consultants available that you can call and ask questions about a fit. They can manage the case with you. They also have, a lot of them have training for staff, and they also have marketing materials that they can provide to you at no cost. So it is a great resource. I've had companies come over to my office and train my staff. So it's definitely, there's a lot of help out there. Now that we got these big players getting involved, there's a lot of free resources.
That's right. Yeah. And I think just one last comment, just going back to your case of that 3-year-old who you prescribe atropine. Did you start at the first visit, or do you normally wait to see some progression and start? Any thoughts over starting atropine for younger kids? Do you wait for progression to be seen, or do you just start it because they are at a risk?
It depends on the risk. So I assess that risk factor for that one particular child to become highly myopic. So if I determine that based on scientific evidence that this child is already at a high risk of developing high myopia, I educate the parent, and if the parent is on board, I like to start right away, because why wait? When I have the only patients that I'm waiting to start is when they are pre-myopic or very low myopia, like less than -1. I can wait, but I'm seeing those patients after initial visit. I'm seeing every patient back in 6 weeks. All patients, regardless whether they're doing myopia management or not. And then after 6 weeks, I see them in 3 months, and then I see them in 6 months. So monitoring is so important. So, I did a lecture with my colleague, Kevin Chan, and he did a wonderful comparison between how we need to look at myopia like glaucoma. So when we have a patient who is at risk of developing glaucoma, we bring them back for monitoring. So what do? If you really look at myopia, just like you look at a glaucoma, there is no question. You see someone who is at risk of developing glaucoma, what do? We educate them about glaucoma. We educate them about what's going to happen if it's left untreated and the importance of monitoring. And if you have available OCT, a visual field, pachymetry, you go ahead and do all those tests to have a baseline. So I see myopia no different. So what I do is I see a patient first time in my office, they are myopic. I'm going to educate them, and I am going to do baseline. So I'm going to take a topo and I'm going to do axial length. Sure. And I'm going to see them back in 6 weeks, regardless of what they want to do.
All right, great. So I think it's more of seeing back, and regular follow-ups is the key, and having those data with you and deciding on what management.
Right. So I do have, also you have to keep in mind, I get a lot of referrals. So I get patients that are already coming for myopia management. So they are here to start the treatment. So usually at the OK Love Clinic, which is just myopia management, patients are coming in, they already had their exam and they were referred by their physician to me because their myopia was progressing. So I do a lot of, implementation on the first day.
Awesome. Great. Okay. So thank you so much, Dr. Glenda, for sharing all of that with us, and, sharing all the expertise with us as well in terms of what happens in your clinic and all that, what we can bring to the clinic once we start back tomorrow. Right. So thank you so much for
thank you.
joining.
Well, thank you everyone for being here on a Sunday. I know it's evening for some of you. So it's morning for us here in America, but you guys have been a great audience. And yes, I will share my email.
Yes. So thank you so much, everyone, for joining in today. Just before we end, I have a couple of announcements to kind of share with you. One of them is just a final reminder. We do have a glaucoma certificate course, which we are planning on the OOLS platform. So if you are interested, more details are also on our website, and you can also scan the QR code, which is on the screen. We do have our 200 session coming up, which is in the next 2 weeks. This is more of how to be an author and the hero of your optometry and life journey. And we welcome you to attend this session as well. If you have any questions, you can always feel free to write to her, or you can write to us, and we can always connect you with Dr. Glenda if there is any need. So take care, everyone. Be safe. Have a good day ahead. And I hope to see you in the next session. Bye-bye.
Thank you. Bye-bye.
Thank you, ma'am. Take care. Bye.